What advanced diagnostics improve TB test interpretation? Imagine trying to solve a complex puzzle where each piece tells part of the story. That's what diagnosing tuberculosis involves. Traditional skin tests have been useful, but advanced diagnostics now help us interpret results more accurately. These newer tests include blood-based assays, called interferon-gamma releases assays, and rapid molecular tests that detect the bacteria's genetic material directly. Interferon-gamma releases assays, or IGRAs, measure how the immune system responds to specific parts of the tuberculosis bacteria. They look for a protein called interferon-gamma released by T cells when they encounter TB antigens. The two main types are quantiferon, TB gold plus, and T-spot TB. Quantiferon measures the amount of interferon-gamma released in a blood sample after incubation with TB-specific antigens. Results are reported as positive, negative, or indeterminate. A positive result suggests TB infection, but it doesn't tell us if the disease is active or latent. Negative results make active infection less likely but do not completely rule it out, especially in people with weakened immune systems. Indeterminate results mean the test was inconclusive, often requiring retesting or alternative methods. T-spot TB counts the number of immune cells that produce interferon-gamma after exposure to TB antigens. It reports results as positive, borderline, negative, or invalid. This test is particularly helpful for people who have received BCG vaccination or have immune suppression because it's less likely to give false positives compared to the traditional tuberculin skin test. The main advantage of IGRAs is their higher specificity and the convenience of a single blood draw, which is easier for patients and healthcare providers. However, they need proper laboratory facilities and can sometimes produce indeterminate results, especially in very immunocompromised individuals. Molecular tests like the Xpert MTB RIF assay are another leap forward. They detect the DNA of the tuberculosis bacteria directly from patient samples, such as sputum. This test is rapid, providing results within a few hours, and it also checks for resistance to rifampicin, an important TB drug. The high sensitivity and specificity of the Xpert test mean it's excellent at confirming active TB, especially in cases where traditional microscopy might miss the bacteria. It's especially useful in diagnosing TB quickly and guiding treatment decisions, including whether the bacteria are resistant to key medications. This helps prevent the use of ineffective drugs and speeds up the start of appropriate therapy. While traditional tuberculin skin tests are still used, they have notable limitations. They can produce false positives in people vaccinated with BCG or exposed to non-tuberculous mycobacteria. They also requiring two visits, one to inject the test and another to read the result after 48 to 72 hours. In immunocompromised patients, the skin test might be falsely negative because their immune response is weaker. That's why advanced diagnostics like IGRAs and molecular tests are increasingly preferred. They offer more accurate, faster, and more specific information. In summary, the use of interferon-gamma releases assays and molecular tests like Xpert MTB RIF has greatly improved how we interpret TB tests. They help distinguish between latent infection and active disease, identify drug resistance early, and provide results faster than traditional methods. This allows healthcare providers to make better informed decisions, tailor treatments, and improve patient outcomes. But remember, no test is perfect on its own. Always consider the full clinical picture, risk factors, and additional diagnostics. Consulting a healthcare professional is essential for accurate diagnosis and appropriate management.